Good afternoon. Thank you for staying around. And I want to shout out Dr. Christina Pardo, who really did all the work for us. And unfortunately, she cannot stay. So I am here to try to synthesize everything that was discussed this morning. But I want to introduce myself, even though Dr. Pardo briefly introduced me earlier. I am Aimee Afable. I know some of you here. I am an associate professor in our Department of Community Health Sciences, and I'm also the associate dean for community engagement. And so it was very inspiring to hear all of you this morning, and I'm hoping we can put together a group of, synthesize our ideas so that we have some action items to share with the group at 4 o'clock. Okay, so here I am holding, and again, I did hear from some of you already this morning, but if you don't mind just repeating your name and your organization, that would be great when we start the conversation. So, to summarize, I have everything that was discussed this morning, and I wanted to, thank you. Thank you. What was your name? Rona? Thank you, Rona. I wanted to summarize everything that we discussed this morning or earlier in the afternoon based on your action plans. Again, the focus areas were transportation, food insecurity, and communication and coordination. How do we connect and coordinate all the services that were discussed earlier this morning, as well as during the report back sessions? How do we ensure smooth operation? Again, I think operation, communications, and coordination all relate to each other. And then finally, we have this action plan. The fifth one is immigration. Again, sorry, because I didn't attend the entire session. We need to be sensitive to concerns regarding immigrant mothers, immigrant pregnant individuals, and obviously sensitive to some of the social determinants of health that obviously are sometimes not as easily modifiable. But as we learned today, there's a ton of resources out there and community organizations that provide these services to address some of these unmet social needs. But how do we work together so that we can leverage those strengths and also be able to close loops in care, right? So I will say from what we heard earlier from all of our panelists, from all of our facilitators, is that there are these resources that exist, but they're right? Where there's fragmentation. And so how do we work together? I want to make sure that we are aware of that type of arrangement. And, and then I want to ask you all if there's if there's an area that we can think of that will, or there is a project that we can think of that will encompass everything that we discussed earlier this morning. Go ahead. Oh, I thought you had a point. Okay. Yeah, so what is the most urgent here? Or do we want to cover everything? Because we have to look at our focus area. We have to talk about the barriers to the project implementation. We have to think about who the lead organizations will be. What is our actual strategy of action, right? So, when we come together at 4 o'clock, we have to be a little bit more concrete in how we're going to actually deliver this project that you all brainstormed this morning. Ideas, are there certain, I like the 3-1-1 idea, and do you want to, maybe we could build on that?
The timeline is 3 months?
So we're thinking of, yes, so let's once we have a project idea, a concrete idea, then we could start thinking about what are the deliverables, or what can we do in 3 months, and then what can we do in 12 months, right? But we need to have, because we discuss a lot here. Let's move towards maybe synthesizing it and coming up with one big project. Perhaps we could think about some of the stakeholders we talked about, at what level do we want it? We talked about, systems, healthcare systems. Do we want to focus on sort of patient education? Do we want to focus on systems change? Or do we want to focus on even higher levels at the policy level, right? And so I definitely, just someone had mentioned, I'm an academic. I know there's a ton of evidence out there. I don't want to sway us either way. But I do know that this 311 idea, I think, is very novel. But again, how do we go about doing that at a higher level? Go ahead.
Okay. We said a lot this morning, so I am just going to maybe touch on everything. We said so much that to roll it out in 3 months, it's tough, even with any budget. The only way it's possible is if identified is an existing agency that provides transportation, an existing agency that works in food security, one that works on some form of communication, and one on immigration. And from the things we discussed, identified one thing that can happen in 3 months, and in collaboration, roll it out. And from our action plan, the things to develop, like the 311 and the access a right thing, is a more long-term policy, strategic intervention. But definitely, I don't know the agencies. If we can identify an agency under each and say, well, we work with 100 individuals in 3 months, or I get a number.
We don't have to implement it in 3 months. What do we want to see? Okay, once we have our idea, what do we want to see in 3 months? Maybe we want to see groups work together to write a proposal to a certain agency. We don't need to implement it in 3 months. So let's come up with what. So it sounds like, what was your name again? Samantha is saying we want to be able to address transportation. We want to be able to address food insecurity and communication, right? So we need to think about what organizations do we think will lead those efforts, initiatives. Go ahead.
Okay, my name is Edwin from MNH Family Healthcare. I beg to differ with the intervention. I believe in 3 months, since we already know the problems associated with maternal health care, child health care, for the beginning, we can invite the lead of each entity, I would say first hospital and some doula. And since we already know the problem, brainstorm it with them and see what solution we can get for the next 3 months to go by. And then for the 311, since we already have a 311 in the community, but that we will need for all 3 boroughs, we can annex these 311 and write the proposal for those 311s to be able to use for the pregnant women, and then submit that proposal to have funding. I don't know how policy works. That's not my forte. I cannot speak on that. But they can write about the 311, so those 311 could be annexed, and how those calls gonna be answered. Are they gonna be answered through the 311 regular channels, or this call has to be separate, which I believe should be for this part of the spectrum. From that point, we can move forward with those information throughout the community and use it to the channels of each entities, probably all of them that were here. And when we get that out, then we can start educate the members of the community. Let's say they're doing the circles around monthly. And when we get to that point, now we have a good prototype of the program, then we can move forward to the resources needed. Yes.
I think the other thing that we could look at are the food banks and food pantries within various areas. and possibly connect them together.
Okay, so what is the name of the program or the stakeholder or who provides the funding for MAS?
So MAS stands for Medical Answering Services. So it's solely dedicated to Medicaid recipients who needs transportation to medical appointments. So once you contact the number, they're going to ask you if you're enrolled. You enroll with your Medicaid ID number, and you must have a specific provider that signs off of the MAS request form. And any medical appointments that you need to go to, you contact the number, you let them know the dates and the time, and they would provide that transportation for you.
Okay, so it sounds like we're not going to focus on one issue. We want a holistic approach, right, to support our pregnant individuals. So we don't have a specific, but what is the focus area? Support, social support, linkage to social resources or community resources. What do we want to call that? Because I'm trying to put together everything. So it sounds like we don't want to just focus on one need. We want to make sure we address whatever, the needs are going to vary, right, depending on who the individual is. So we want to have an opportunity to provide, be able to support in any area possible, right? So is that what we're saying we want to be able to do? Okay. Okay, so resource center. So do we have like a creative name? Like, what do we call it?
I was trying to find it.
Go ahead.
Connection to care.
Connection to care. I like that. Connection to care. Okay, so can we call that our focus area?
Yes.
Okay. Connection to care. Okay, and then another commonality across is we want a hotline almost, right? It's a hotline. Connection to care hotline. Okay, but how are we going to implement? It's going to be regional? So by borough, by what?
By borough.
By borough? So it's like a 311. Okay, so borough specific, right? That is our focus area, is connection to care, a connection to care hotline that's borough specific.
So since we already have some of the agencies already existing, I think she's a professor. She did speak strongly on holding these existing agencies accountable. So I think there should be some space in our Connection to Care resource center where we have attorneys that can help lobby or help write letters or petitions to hold them accountable for these underserved areas like Bronxville, wherever we are.
Okay, so part of, so then that's elaborating on what kind of services Connections to Care can provide or link our pregnant individuals to. Is that what you're saying? So.
Also, like, not just having another layer of holding them accountable. Like, you exist already. We're trying to link everybody. Please work on board or, make sure we get the funding that we need.
Ensuring closed loop?
Yes.
Referral?
Closed loop referral, but also, I don't know if you can elaborate further because I'm piggybacking off of her point where, like, Medicaid already has transport programs for people. There are, these things already exist, but why is it that it's not functioning at capacity in these areas?
And what we need to do is we need to implement this program, first of all, and then we need to evaluate it. And then we need to see what is the efficacy and how well did it achieve what we wanted to achieve. So I understand your point. So how can we show people in power? How can we persuade them, you know what, I want a 311 per borough in New York City that provides connection to care regardless, depending on what the needs are. Look, it worked, and we saw these improvements. So let me know, what do you think we should be measuring if this is the case? If we're going to roll this out, what do you think we should be measuring to show impact of this program? Because the problem is that there's a wealth of resources in New York City, and we already discussed that. But no one has systematically evaluated the efficacy and utility of these resources and the lack of capacity that exists among the CBOs. Yes. So, and that's going back to your earlier point, right? We need a community needs assessment or asset mapping, right? We need to do asset mapping. So, forget about the taxes. No auditing, no auditing. I mean, that's a whole. You have to ask Mamdani about that. Like, he just audited the entire budget, and so we already know we're like how much in debt already. So, but we need to understand the gaps, the capacity, the lack of the areas where capacity is needed, or where areas where the capacity is full and is enough. So we have to be able to do an asset mapping study, community asset mapping study. And I actually am partnering with Brooklyn Perinatal Network, for those of you that don't know, or who know them. We're starting that survey already. So don't worry, when we have it ready, I'm going to reach out to every single one of you to have you to fill it out. But we definitely need a systematic study of the assets in our community and also what's missing among our community organizations in terms of services, but within the organization, what capacity do they need as well, right?
Okay, so yeah, thanks for bringing that up. I think that we should pick like 3 main areas. I think we already touched on food, shelter, or housing, and transportation. So that would be 3 key focus areas.
Okay, so,
We could take it.
again, so we want food,
Food, shelter, transportation, or food, housing, transportation.
food, housing, and then transport.
Okay.
Okay.
Then we need a list of 50 organizations that target those areas. They have them already in the city. 50. We can brainstorm 50.
Housing and transport. There's others. What else are we?
Food, housing, or shelter, and transportation.
And then legal support, right?
Yeah, so we need a list of 50 organizations that already work in that area to contact within the first month. Okay, as for legal services,
So again, there are platforms I mentioned this morning.
Yeah.
Unite Us, the social care network, they all can give us access to a centralized database where we could find the support. So there are digital platforms that exist where we could do this.
yeah. We have the New York City Public Advocate that's already available. So they work with the city agencies.
Wait, is it the public, who, Jamani
New York
Williams?
City Public, yeah. Yeah,
Jamani Williams?
yeah, they're pretty decent. They're pretty, I mean, if you get somebody, sometimes we're working sometimes, they could be better,
So-
but he cares, yeah.
So all I'm saying is, for this, there are, Unite Us is one example, but these are web-based or digital platforms that have an inventory of all the resources across New York City, right? Web-based resource platform. Yes, so if you look up, I know, who was I just speaking with? Unite Us is one, Find Help is another. Do we have CBOs here? Don't you use other platforms? I thought, are you part of a CBO? Oh, Unite Us? What other platform? There was Find Help. What was the other one? Someone said something else this morning. Okay.
Or the social care network.
Okay, well, I'm going to just write Unite Us is one. And then there's also Find Help. If you guys Google these now, you'll see that you could, generally Unite Us is designed for a case manager, a community health worker, who goes into the platform, they screen for everything that we just spoke about, and based on what the client screens positive for, they'll get a list of referrals, depending on whatever the need is. Okay, the beauty of Unite Us is that you can go back in here and check if we actually close a loop. So we send the referral, she or he accepts the referral, And then you could see if the CBO says, oh, I accepted that referral, or no, I don't have capacity. So that's what this does. Oh yeah, Jafane has experience with it. She used Unite Us. So these are web-based referrals. This is a way to organize some of these things, right? And send out referrals. But what else were we gonna say? Sorry.
So we need to meet with like key city officials that handle 311. So we have to find out who handles what.
Okay, so now we go back to stakeholders. We were saying hospitals, doulas, food banks, right? And legal services, and then
Like the patient
New York
advocate,
City,
yeah.
like politicians, local politicians,
Yeah.
right? These are all stakeholders. And so I think that's part of, once we have an idea, we want to meet with New York City, because you know, New York City Council has money. They have we can ask for funding from them, but you know, they have specific grant timelines.
The other thing is also the borough president's office.
And the borough president's
The
office.
borough president's office in Brooklyn has a lot of information, and they have events over there for maternal health,
Yes.
mental health, everything, dental, everything. So the borough president's office is one office that should be really looked into and used, utilized to the full capacity, because we're in Brooklyn.
So the Brooklyn Borough President's Office, the New York City Council, up until the, you know, obviously, we also want to work with the DOH, right? The New York City Department of Health. Yeah, New York City DOH. Sorry, are we still having, I'm totally, are we online? Oh, okay. Okay, lactation. So lactation, does that work with the doula organizations? So maybe we could group that with doula organization, food, housing, transportation we have. Okay. Like, oh, birth workers, yeah, like midwives, and also community health workers, right? So, what were we calling them? Birth workers. Birth workers. Birth workers, yeah. So, now, how much time do we have? Okay, I want us to think about specific organizations now. So we have, are we thinking of anything else for that 311 call, for the 311 intervention? So the idea is they call this number, right? Who's gonna answer the phone?
Okay, so we can have a sub-department within the 311 office, right? And then we can, since it's going to be borough-based, we have a Brooklyn resident there, provide all of the CBOs, all of the resources that they can provide. If it's specifically for maternal health, we should have maybe like a fact sheet or like I don't know, yeah, like a fact sheet to provide to them. And then once it's called, I mean, it can go directly to the main 311 center. And then if it's like for Brooklyn, it can be directed to that specific department, ideally.
Okay, so we could have a borough-specific office that handles all the calls.
Yeah.
And then, who's going to handle the call? I heard someone say here. Okay. Go ahead.
I was thinking maybe community health workers or birth workers, like some people who have the expertise in this particular area. And that, to your point, that also know the borough.
Yeah, so we'll have a borough-specific call center and the staff would be the birth workers, community health workers, doulas, and then the staff would be birth workers. Okay, so now that, you know, this is, because we're asking for a borough-specific 311, yep.
about the 311, what she says, to call like a Bow community center to answer the calls. You know, when you call 311, if you call, that call is for a specific reason, they will transfer the calls. We believe those calls should be associated within hospitals or doula organizations. When somebody calls 311, they transfer you to hospital, or let's say if I call, they already know which part of the city that I call, which street of the city that I call. If I call from that street, this is the hospital that is closer to me. That calls should go to that hospital center for somebody to answer and assess that questions. That way, it would be easier instead of somebody going around get an information for specific things, because each pregnant person follow a clinic or a hospital.
Okay.
So those calls should be directed through that.
You raise an important point. I forgot about this. This is for pregnant individuals. What if they have medical questions, right? So we need a fifth area here about medical or health education, right? So medical.
Should be community outreach, something like that.
medical, health information. Right, because I think someone said that earlier, a lot of I don't know if this was, not everybody's educated about some of the key, like, warning signs that pregnant women should know when they're carrying a child, right? So, for example, I just think about the women, has everyone seen Aftershock, the documentary? It documents the maternal death of two local New York City women, one here in Brooklyn, the other is in the Bronx, but they fell through the cracks, right? The woman was calling 911 because of pulmonary, she was getting chest pains, but that person on the other line didn't take her seriously and dismissed that. And then what happened? She by the time she got to the hospital, it was too late, right? And so I guess my point here is we need to ensure that, yes, we want the hotline to be able to provide these support services, but we also want to, for these types of cases, when you don't have a regular source of care, you need something to rely on for that crucial information at that moment. And so, so I think, how do you all think we should deal with that? So, they call, and what if they have a medical emergency? So that person, we also might want to make sure that we train our birth workers on how to respond to these kinds of things. They may not have the capacity or training to do it, but then they could refer immediately to a physician or 911. We need a escalation protocol for these kinds of things as well.
But like even when you call 311, it would be the same thing, because if you call 311, it's an emergency, they want you to call 911. And 911, that's their job to handle any emergency situation. 311 is an informational call. So if the person if each call, probably, if it was just the call center answering the 311 calls, you wouldn't be able to give information to a pregnant person that need information. But if all these calls from boroughs go to hospitals or healthcare centers, so those calls should be able to be answered. And even when 311 calls is made and those call centers, hospital answers, if the person has an emergency, they still can refer you. You come to the hospital directly, immediately, or you call 911, because we still have to separate 911 from 311, because you don't want one to overlap with the other one.
Okay, but you raised an important point. Okay, so are we saying we're going to move from we're going to call 311, 311 is going to refer to us, or do we want our own line? I think we need our own line. Yeah, yes. Okay, just double. Okay, go ahead. Okay, so what is our number?
Because if you call 311 right now, like I just called 311 because I wanted to hear like all of the menu options. And there's housing, there's property taxes, there's this, there's that. Call 911 for emergencies. We should stray away from 311. If this is for maternal health and more maternal whatever we want to call it, it should be connection to care hotline, period, point blank.
That's
Okay,
it.
so it's not neither of that. So we have our
And one more thing, I think we should also consider making it an app. Yeah,
okay.
they don't use the telephone. Exactly.
Or
Yeah,
it could be, what about just you text to this number?
or that QR codes, like all the bells and whistles for technology.
Or
Yeah.
SMS?
Yeah.
I don't know.
But
text
stray
or
away
app.
from 311 because that
Oh,
can
it's
be
not
very,
three, yeah, we
Yeah.
don't want, we want our own hotline. Okay, what is our
Yes.
hotline? What's the number? No, seriously, because we need to come up, we're going to be presenting this to Mayor Mandani next week. What is it?
No, it should be a
666.
three. It should be
Oh,
a
no, that's
three-digit
bad.
number, so it can be easy, like
God, I'm
911.
6'6" too.
Oh, 211. Somebody said 211.
Oh, 211, yes, that's an old school New York City. No, 212.
No, that's Manhattan.
Manhattan.
Oh, okay. Okay,
718. Well, that's what you just. Yeah.
Brooklyn.
okay, that's the borough, that's the Brooklyn borough. Okay, that's a-
But if this is gonna be borough-based, shouldn't
Yes.
it be just like a very generic number so it could go like based on your borough?
yeah, that's true, it's borough
So it
based.
shouldn't be 718.
But the thing, my concern about borough based is that some people in Brooklyn, for example, they live closer to the Queens.
Yeah.
And I mean, Manhattan's his own thing.
Right.
But like people in Brooklyn live, like what about Bushwick, and Ridgewood? They're right next to each other. I think it should be near Manhattan and Bronx, and then Brooklyn and Queens.
Yeah, it's the same island, Brooklyn.
Yes, that's what I'm saying. And then Staten Island on its own.
Could the number?
Okay, so do we all agree? Should we do Brooklyn? I know Manhattan and Bronx because they're close to each other, and then Brooklyn, Queens, and then Staten Island on their own.
Oh, no.
You have to call the Manhattan line.
Can we have?
Okay, go ahead.
Can we have the words? You know how they have like 1-800 CARS USA or whatever. Like maybe we could have connect somehow have the name of the hotline as part of it. So like 718 Go Connect or something. I don't know, but that has all of the. Yeah.
Oh, awesome. Oh, 1-800-MOMS.
Well,
And then you just press your borough. Oh, that's true. Well, not everyone giving birth is necessarily a mom. So should we have?
But this still applies as a mom. You want to be sensitive.
Yeah, we have to be sensitive to the wording. So what is? Anyway, but I still like the 1-800. Let's think about it. And okay, so are we saying now it's region specific? So we're gonna group whatever they could call that hotline, and then they say 1 for Bronx and Manhattan, 2 for Brooklyn and Queens, 3 for Staten Island. Okay, so 1-800 something. Baby, 1-800 baby. 1-800. What about people on Zoom? What do you think? 1-800 baby. Connect. 1-800 NYC. What about 1-800 NYC Cares? 1-800 NYC Cares. Is that too many? No, we need to put New York there. Oh, NYC Care. Okay. NYC Care. Yay, we have. Yay. Okay. Okay, so I'm not clear on the strategy. So we have these region-specific call centers, and then what happens? So region-specific. And then they call in. We have region-specific call centers. At those call centers, we have birth workers who are staffing them, right? And then they need to be trained. Obviously, we want to, if we're hiring doulas and community health workers, they have their own training, but we want to do an additional training. Yes, we need to do an additional training to talk about all the, to train them on how to navigate these web-based referrals, how to provide medical and health information, and what to do in case of an emergency, right? So, because you could just have a lot of pregnant individuals calling in because they need support or they're struggling. Those are not necessarily like emergencies, right? So now for those kinds of people calling in, they need to be trained on how to triage or speak to them at the moment or refer to mental health if it needs to be done. Yes, okay, that's right. There has to be multiple languages. So these have to be, they have to be trained, we have to make sure we have birth workers that are multilingual.
So birth workers should be trained in domestic violence situations on when if someone calls in that has that type of scenario, they'll know what to look out for, what kind of keywords to understand. And so that's something that should be in the training as well.
Yeah, so then we could partner with, we have, don't we have a mental health group here? We could partner with Agape Family Therapy. They do these kinds of trainings. They actually train community health workers to provide community health workers support, but also they train community health workers how to provide support for clients as well. So they can do that as well. So.
Okay, so we need to have, within I guess, experts here in the room, we also need the tech people. So we need like our ideas and a tech person to help design the app. So a lot of things we're talking about can be they call the outline when they see what borough or where are you nearby, because some people are homeless, right? Where are you nearby? Once they say a borough, they click on the app, the person receiving the click on the app, and now you have resources for Brooklyn or resources for the Bronx, okay? Are you bilingual? Someone click on the app, someone Spanish or Hispanic, gets the call, or someone Chinese gets the call. So that could be done in tech sector that's they only call in one person, and that person routes them in quickly to the next person. So we need a nice tech foundation. And also, we need to, I think the first month should be a meeting with the city officials, a meeting with the social care workers in the hospitals already. We didn't talk about the churches and the mosque. Churches, mosques, synagogues, temples. Just have a meeting with some of the people that already handle in the community, because a lot of people are not comfortable. The Catholic Church is huge. A lot of people are not comfortable going to anywhere but the church, maybe, and meeting so that they can know what we have available. Also, let's do a calendar of events. Mm-hmm. Those groups are already doing something that we know about. Let's see what they have planned for the year, and let's put the calendar of events. What's good to send our parents to? What should we attend? Like NYU has something coming up pretty soon. Some of us should be there. So NYU is big in healthcare workers, community healthcare workers. Let's see what's already available, and let's kind of tap into that instead of redesigning what's already been designed.
So that's a great point, because we didn't speak about faith-based organizations. So I think once we have a prototype, we can then present it to them and see how we can work together to either promote it, or are you thinking they have like an operational role in this?
We should invite them, like, most of them say they're busy, right? There's always one or two people that's really into it. Invite them to come sit down and invite them in designing the process. Mm-hmm. So usually they're an afterthought, but they play a huge role with immigrant communities, with low-income communities. They do with refugees already. Refugees, one comes into mind, what's the name of it? They're based in the Bronx. I can't think of the name of it right now, but they come to mind that they deal with people that are underground that don't talk to anybody. They bring them together and they have them over for dinner. I can't think of the name right now. They're based in the Bronx. It'll come to me. But they deal with that community already that only trusts the church, only trusts the nuns, only trusts someone that looks like them. So we need to, talk to them. We don't need names or anything, but guess what? We have these resources. We are independent, and we could give you the resources and please have them get to this person. And also in designing, make it clear that we will not identify anybody. with the ICE situation, and for anybody, we're not going to ask you country of origin. We're not going to ask you, questions that could identify you. Let's make that very clear. And that's the issue with asking for city funding. Let's be careful about the funding. They might start asking. We have to work it out that they will not require those things so that the mother gets help. If anything, if a child is being born in New York City, they're in New York City. They're already a citizen if they're being born here, at least for now, right? So.
Can I also add that for patients being discharged from the hospital, a lot of the patients are frequent flyers. We need to somehow get an informational flyer to those patients that are repeatedly hospitalized, are being discharged. The social worker comes and they give them information, but they should have a cheat sheet where they can refer, like if they have a problem such as what brought them in the hospital or any other problem regarding their issue, who can they call in our agency so that they don't have to come back to the hospital for uncontrolled blood pressure, uncontrolled diabetes, or because they ate wrong or ate the wrong foods, or their pressure went up because they didn't follow appropriate diet. So somehow we need to get all of this information on a sheet and get it to the patient upon discharge so that, one, they have that information. Two, they have somebody in the community that will make sure that they can follow up or follow through with whatever recommendations we make.
Can we do that with our hotline?
Yeah, but a lot of people, I mean, even young people, they need paper, right? No, maybe not. No.
We don't need, no one, they don't need paper anymore.
They go. Yeah.
Dr. Graham Hill, she is a, are you an obstetrician? You're a cardiologist. Are you an obstetrician too?
No, just cardiology.
Cardiologist.
Yeah.
So she is our provider, also representative here. So no, this is important because we want to be able to reduce readmission, right? And prevent, any kind of severe sequelae that might exist, that probably might happen once they are discharged. So how do we, I think that's an important point.
I think in instances like this, marketing is a really big thing. And so people like bright lights, all the bells and the whistles, especially young people, right? And this is where this comes in. This is where we get the website going. You have an app. Oh, can I download the app? There's a QR code. The QR code leads you directly to wherever, and this is the lane that we're going in. AI. If we can get something that can connect to an AI that can give them information on something, that would definitely close the gap between, because even myself, my doctors give me papers. Here's your summary, and I'm like, okay. And I'm not looking at that. I go online to my chart, and I look at my chart and see all the information. Paper means nothing to me, unfortunately. So, yeah.
So that's an important point. So how do we automate guidance that patients are given at discharge? So I don't know how we could integrate that into here somehow.
Yeah, unfortunately, thankfully, you're not the audience. For this, you're not the audience. You have multiple degrees. You're highly educated. You understand how to, do this, or even learn the program this, right? If you are running from ICE, if you are an immigrant, if you don't have your papers, if you are not stable in the country, you might not want to use even WhatsApp. Has become dangerous. So the targeting WhatsApp. Before this, WhatsApp groups would have been excellent because they used to call their country. So it's really important that we think about that.
So can you repeat that? So they're not using WhatsApp anymore? What's going on
People
with
are
WhatsApp?
scared because, I'm a tech person too, people. I told you, multiple degrees, right? I have a cybersecurity background, okay? I was behind Walker State University, one of the people recruited to the board of directors for cybersecurity from 2017, Walker State University, right? We created one of the first programs they had in the country. Okay. It's the easiest way for me to track anybody here, or for anyone to track anybody here, your cell phone number, very easy. your email, very easy. So Google has access to every app you visited. So who owns WhatsApp? Meta? Who owns Google? Yeah. What I'm saying
Is
is
this
that
reaching that community?
yeah, we are reaching immigrant communities, a lot of whom do not have an associate degree. By the way, most Americans do not have an associate degree. That's important, right? They might be using computers to make calls, whatever, but they will not access something they think might be tied to the city, NYC, whatever. They will not access that because right now people are scared. Not only, maybe they're legal, but their family members are not. So they are targeting even like projects, homes, where you have the father's legal, the mother's not legal, whatever, they're being targeted right now. So, like I said earlier, it's more work to do. Apps are fun. It's more work, but you have to work with the local communities, the mosques, the African community, the West Indian community, they still use flyers. It's boring, but they use flyers, right? And by the way, in terms of being eco-friendly, whatever, like I said, that's my background too. These things emit a lot of, carbon. There's a lot of carbon issues with the data stuff, okay? So meaning like they're actually more dangerous than paper, okay, when it comes to saving energy. So the immigrant community still like those postcards and the flyers. Certainly could put it in front of a church or a mosque, right? When they're attending Sunday service, maybe stand by the door to do it. Have someone talk to them, then you leave. So working with people already in that community, the women's group, the daddy's group, the mommy's group, let's do it that way. Yes, the apps are, you also have the app, because they are, also have the app. By the way, NYU also has like legal, the student legal care they've offered to help me out before. The schools have that already. So they could have some student tech people. Columbia has some, students that they could hire to do the tech stuff. So we could save money that way, right? But still have the paper. The boring stuff, still have it, because the people we're dealing with do not even speak English or barely understand English. Yeah. What I'm saying is because, what I'm saying, like to us here, okay, app sounds great. I like app. Also have the app for the children to access things, right? But do understand the people that really need it will not do the app. There's too many apps out there, right? You need to use the churches, the food banks, the homeless shelters, okay? And have someone that looks like them in the community. Talk to them in their language. It's very important that you do it that way,
Yeah. At this point, they're scared in the community. I just heard recently, I think last week, that because of the new regulations of the Trump administration, they're taking away TPS.
I think that's why it's very important to allocate funds towards community health workers, because that's what they're here for. They're doing the work in the community. They're doing outreach and getting that connection with the individuals that actually need those assistance. Yeah.
I just wanted to add for the faith-based groups that I feel like maybe sometimes they're under the radar, and they can also be sources for resources for food, housing, and transport. So that's another way that we could integrate them, is like if they filled out a survey to talk about what kind of services they offer as part of a church. And also, I feel like what I'm hearing is that there's this component of a hotline, but there's also like an in real life strategy where we have, and maybe this is where we're partnering with community-based organizations to have them on the ground to distribute the information that we're developing.
Yes, and I think, here the idea is that it's a hotline, and, the app or the text system is just, the various modalities that we're going to operationalize this, right? Whatever they prefer, they're going to use that. But we need a way to get this hard-to-reach population comfortable and trust, and they need to be able to trust these modalities or these projects, or we need to assign trust to these hotlines or the way we brand it. It matters. So I think, once we have this idea, then we take it to the faith-based groups, the other organizations that are working directly with these organizations to promote it and to let them know, you know what? We're going to, all of these regional call centers are staffed with multilingual community health workers that are from your community. We have to ensure that that's, I'll write that down, that they're matched with regard to culture and language. But I think part of it is, as long as we could disseminate it throughout those networks, we could build brand trust with this, and hopefully we could reach that population.
And maybe it's circular so that we're actually recruiting from those organizations, or like from faith-based organizations in particular. There might be people who would be interested in becoming community health workers or doulas, and that way it's kind of a circular thing.
Yeah, so we have here, our focus area is Connection to Care, 1-800 New York City Care, and it's a hotline that we can call, but it also can be an app, and it also could be, are we gonna do text?
Or they're so quiet. They stay quiet. Yes.
Oh, because they don't, see, because they're screening. Do you answer your phone? No one, I don't know. No one wants to pick up from a phone number they don't recognize. That's why we need to do brand marketing of our new hotline.
I was confused. I keep calling people, and
No, they don't want to pick up an on.
and then they call you back, and they were like, "You call so," and I'm like, "Yeah, I just called you. Why don't you pick up the phone?"
Okay, we have 10, 20 minutes. Okay, so here.
We were speaking about how to pass the information along on discharge, and I'm also thinking like in the after visit summary, we can put like under the education, whether it's the 1-800 NYC Care, or I don't know if there's a way to even put the QR code, but on discharge, we can make sure that every patient being discharged, like from whatever clinic, it's part of the after visit summary.
Oh, that's a good idea.
I have a question. So my question is, we're talking about all this, and I'm bringing it back to funding, right, and money. How much money do you think
Okay, that's
something
a
like
good idea, because she's telling me what to do next. Oh, we're supposed to come up with resources needed. Yes, so let's go to the next one. So number 3, does anyone, before we get to resources, do we need to write anything else down? So this is our focus area. And I'll get to, when we talk about resources, let's talk about really naming the stakeholders. Who do we want to really partner with for this? But is there anything else missing in strategy that we need to add? So basically the strategy, we have regional specific call centers that are going to be staffed by birth workers who are multilingual and multicultural, and preferably they're coming from the communities that the populations we're serving are from. And they're going to be trained on how to use these sort of web-based resources and provide and connect clients to care. And they're also going to be trained in escalation protocols for mental health support, for domestic violence, et cetera, or even urgent medical emergency needs as well. They need to know what to screen for 911 as well. Oh, can we write down 911 there? And then what else in the strategy am I missing?
Not to mess it up for anybody, there's already an NYC Care. So,
Okay, so
311 already has NYC Care. So you might want to do Mom Care or Mom Care, something like that. Yeah, because then already an NYC Care.
21, or what about, why didn't we like baby, 1-800-BABY? Yeah, why don't we like that?
because it's not always about the baby. It's about
Oh, that's true.
It's holistic. It's about
Okay, fine, that's true, that's true. Okay, we'll think about that. We'll figure that out. Okay, can we move on to resources now? Yes, let's move on to resources. Okay. Okay, so resources, how much money do we need? Go ahead.
1,000,000 times 3.
Okay,
Times 3.
so what? No, okay.
Oh, just times 3.
No, let's think about what we actually need. The hotline shouldn't be expensive. Like we could get a phone number. That's not a big deal.
You gotta get somebody to answer the phone.
Okay, so
pay
we need to
them.
think about what is the staffing, right? So back at the strategy. The strategies, we have a regional specific birthing center, regional specific calling centers with staff with birth workers. So we have Manhattan, Bronx, we have Staten Island, we have Brooklyn and Queens, so 3. So if we have 3 call centers, how many community health workers or how many birthing workers do we need per call center? Because just imagine, we're a city of 8 million people. How many babies do we get per year?
A lot.
Oh, in New York City?
Give you a Rachel. From
Well, I do know that, just in my work with community health workers, Jafane was one. They can only handle a caseload at like 20 per, even 20 is probably too much. Okay. So let's just say, per region, 3 regions, we have a call center. We want to staff an entire birth worker workforce or CHW workforce. So 100, I don't know, per.
Around the clock, right?
yeah, because it's with 24-hour. Yeah. Yeah.
So, it has to be 24 hours because emergencies don't happen during 9 to 5, right? So,
I like that. 1-800-SAFE-BIRTH.
oh,
That's
safe
on the
birth.
Zoom.
Yes.
I like that. It might have to take off the E or take off the.
Okay, so we have, I like that, 100 safe birth. But that's great. Okay, so resources, so staff, let's just say 100 per region? 100, okay, and then let's assume we're paying, how much is a community health worker? No, not what it is. What do we think they deserve? And that's what we should use.
I'm a community health worker, and I think I deserve way more than I get. So,
Because the thing is, we need to understand, that's a whole nother conversation. We need to sort of standardize competencies for community health workers, and that's the reason why there's so much variation. But, okay, so let's say, $100,000? Per community health worker? No? Okay, but we have to think about benefits.
100,000? No, that's too much.
Okay, so like 80,000, including benefits.
Oh,
Including benefits. Benefits are a lot.
75. I like.
What did they say? 75. Okay, so 75 with benefits. So 75,000 times 100 is $750,000. So you're right, 3 times $1 million. Almost.
Million.
Yeah. Yes. So
What'd you say?
she said, that's true. Last year, community health workers were being paid $40,000 a year. Okay, so if we're doing 75K, including benefits for a community health worker, 100 per call center, that's 750,000 per. What? No, three regions. We have 3 regions, 100 per region. Okay. What is it? Oh, okay. I am dropping digits? Wait, you need to add 2 digits. Sorry. Okay, so 75,000 and you add 2 digits. Oh, there, that's too expensive. But anyway, let's just say.
Okay.
Okay. Let's just say those are the resources we need.
Hello.
75K is a lot for.
Okay, you're my finance person. You're going to present it to the audience because I didn't do those numbers. 30 million per year for the 3 call centers.
And it's nothing when you look at declining birth rate and the value of a consistent birth rate in terms of maintaining your, growth rate and support of the older population and social security number. It's 30 million, it's nothing.
Okay, so but at least that is anchored towards 100 community health workers per region. Yeah, 30 million is nothing when our Department of Homeland Security lead spent 250 million on 2 jets. That's nothing.
Hey, okay, as a finance person, okay, finance MBA here. Okay, it's a tough argument to justify $60,000 or $75,000 to community health care worker. I'm not saying the work is not great, but it's a tough argument to justify that. Why don't we already have people working there? Maybe they could do 10 more hours a week towards this. So you're doing a supplemental income for them in addition to what they already have. Yeah, so, because you have to save money somehow to get this through. As opposed to paying the whole $70,000 or the whole $50,000 or $60,000, maybe $20,000 extra.
Okay, so why don't we just cut this in half? Let's just say 50 community health workers per region. So that's cut in half. 15 million. So it's 15 million. So we're supplementing this current staff, wherever we're going to staff them. We're going to staff them maybe at the DOH. I don't know where we're going to staff them. Okay, so let's think about that now. But we could always play with that number. But the idea is if we're going to do 100 community health workers per region, it is $30 million, right? It's true, because that's modest. What did we say? 75,000 including benefits. That's a modest. Okay, yes, so it's negotiable. Okay, so but let's think about now what is the setting? Where are we going to place our call centers? Is it going to be independent, or are they going to be part of hospital systems, or are they going to be part of the DOH? Where are they going to be part of? Where does it make sense?
So the DOH has a mom and baby department where they have community health workers and public advocates, I think, that go out into the community to help with breastfeeding. They help them, postpartum. Yeah. So I'm thinking that maybe that particular department, or even Healthy Start Brooklyn, you can use. Yeah, we can start in those departments because the DOH is broken up into different areas, right?
Okay.
And I think like the mom and baby for sure is a department where I think it would be.
Yeah, so we could locate them or co-locate them in Department of Health offices across the city. So you mentioned the Mom and Baby project. They also have a new initiative called the Neighborhood Stress-Free Zone.
Oh.
Right? So that's happening here also in Brooklyn. So we could co-locate with their neighborhood stress-free zones as well. Again, that's in its infancy. I'm not sure how it's being operationalized right now, but we could co-locate with them. So we're thinking that this workforce will be located or co-located in DOH settings, right? Or not in hospitals, or what? Yes.
Yes.
Yeah. So there are neighborhood action zone. Brownsville is one. Central Brooklyn, the neighborhood action zones are primarily in historically marginalized areas. So Central Brooklyn is one. There's one in East Harlem, and there's one in South Bronx. So we could also co-locate with the neighborhood stress-free zones, the, what did I call them? Neighborhood action centers? Neighborhood action centers?
Yes, neighborhood action centers.
Yes, neighborhood action centers. And okay, so then basically we have to reach out to the DOH and get their buy-in. So we'll work through our
Public Fund.
Huh?
Fund for this New York City Public Fund. Is that what it's called? Those are my employers.
But no, I know that numbers are large, but we're asking for systems change. This is so now we're talking about city level change. We're talking about governing structures, and we're changing governing structures, right? So there's nothing wrong when asking for $15 million for a community or birth worker healthcare workforce across a city of 8 million people. That's not unreasonable. My finance, you're going to be presenting the resources, okay? Anything else in resource? You had something to say.
And you actually, when you make contact with the other agencies, you're actually creating synergies. So people may have not be utilizing their resources to the full extent, so they may have space in their budget to help supplement.
Okay, a timeline. What is our timeline? Okay, so 3 months, we're going to, what are we going to do in 3 months? We're going to meet with all our stakeholders to introduce our prototype and refine it. Community asset mapping or needs assessment. Okay, so within the 3 months, we're going to meet with our stakeholders, present our prototype, refine, and do a community asset mapping project, right? Or community needs assessment, community asset mapping. But that's actually not it takes longer than that. I'm gonna say we need 6 months to do that. So, yes. Okay, so after 3 months, yes, we start meeting, in 3 months we meet with stakeholders. We need another 3 months to conduct the community asset mapping. So that's gonna be total 6 months.
I have a question, I'm
Yeah.
sorry. So in the timeline, it says, one part it says secure space, right? And in my mind, I'm like, the world that we live in today, we don't necessarily need a space right away,
Yeah, no, we
right?
don't.
Because we can use the hotline, people can work from home and things like that, okay.
Well, we need a space for our community health workers, or birth workers,
Not necessarily.
the call centers. Oh, yeah, they could be
They can do that at home,
oh, yeah, that's a good idea.
no?
What?
A lot of people that were staying home during COVID have to mandate their workers go back to work. Because before, most people, the way they train this part of the world, if they don't work well, it's not so bad. So we're going to lose a lot of money.
Well, it also depends on the policy. It also depends on how the supervision that so like you can work from home, but these are the things that you need to do while you're working at home. You have to report this in. If you don't report that in, then you're going to be in trouble. Like there's structures that you can utilize while, working from home. But, that's, yeah, absolutely.
Okay.
I was just wondering if from a policy and advocacy standpoint, if there would be an appetite for wanting to advocate for, like a city council initiative that is supporting this, like.
Absolutely. I think they should be our stakeholders too. So let's write down so we have resources and our timeline. So, okay, in a year, what do we expect? What? It's a lot of work. It's ambitious, but there's no reason we can't. We've all been advocating for decades. So in 12 months, we'll have our final prototype, yes. And then we pilot it, and we have to meet with city leaders. First we'll work with our faith-based organizations, our community-based organizations, and our city council members, and then in 1 year, we'll be ready to present it to the big wigs, to the actual leaders who are making the decisions for this big project. Anything else?
Yeah.
It seems very ideal and ambitious, but I think it's feasible.
I got one more thing. So to have fun, I put this in Google AI, okay? You need $21 to $25.5 million.
Say that again?
$21 to $25.5 million, okay, to get this done for the first year. So that will cover the
That's with,
direct labor and employment personnel, operation and multi-borough logistics, okay? Funding and reimbursement strategy, some people need, whatever, Medicaid, whatever. Operation capital warnings and a bunch of healthcare where you have to deal with HIPAA compliance, training them, all that stuff. It's a amount around $25 million that's needed.
well, that's
Per
what it
year.
is.
I mean, for your first year, so
For
you
the
might go
first
down a
year,
little bit
the
after that.
operating expenses. Okay, so I think, do we have any last-minute changes? My finance woman, she's going to be presenting the proposal. Okay, awesome. So 1-800-SAFE-BIRTH, that's what it is. I love that. That was great. That's all on you, you all.
On behalf of all of our transport leadership, our planning committee, our Brooklyn-based organizations, we just want to thank everyone so much for their physical presence, their engagement, contributing to all of their intellectual ideas. Again, a huge thanks to our transport PIs, Drs. Riley, Salafu, Booten Foster, Lambert. We appreciate you. To Lakia and Dr. Straker, thank you so much for all of the work that you do behind the scenes all year round. Our organizations who continue to come back and show up and show out every single day. Our new organizations who came to the table, welcome. Welcome to the transport family, to the Downstate community. We look forward to seeing everybody next year. I want to thank everybody who's been online. We still have 30 participants online on a Friday from 8:30 in the morning to 4 p.m. You're appreciated, you're seen, your contributions will be heard and recognized. I want to thank our funders. We talked a lot about funding struggles and challenges that we've experienced throughout this last year. I want to thank New York Community Trust for supporting New York Community Connect. We've talked a lot about that platform, and I've heard a lot of different ways in which we plan to engage and utilize that platform to help implement some of our plans of action that we have over the year. I also want to highlight that transport is supported through the John Lewis NIMHD Research Endowment. And so it is so important for National Institutes of Health, especially the National Institute on Minority Health and Health Disparities, to continue to be here and to continue to use the name and to continue to center and make visible minority health and health disparities. It is not lost upon us that the endowment is named after John Lewis, the great Senator John Lewis, and so Congressman. And so I want to end by just giving a particular quote that I hope that can inspire us and help us to continue the call for action. We tend to use parts of this quote, but I want to give the full quote because I think it's important. Do not get lost in a sea of despair. Be hopeful, be optimistic. Our struggle is not the struggle of a day, of a week, of a month, or a year. It is the struggle of a lifetime. Never, ever be afraid to make some noise and get in good trouble, necessary trouble, and help redeem the soul of America. Thank you, everybody.